before starting, I'd really like to thank CHIP and the Data2 Foundation for giving me the possibility to present this data, and to be here in this really amazing Congress. In the next 15 minutes, I'll give you some data about a monocentric cohort of Data2 patients followed at Bambino Gesù Children's Hospital in Rome, and focusing most on the clinical phenotype, the response to treatment, and the role of type 1 interferon. We have already heard a lot this morning. So this is an update of a previously published work in 2018 from our group, in which actually we demonstrated an increased type 1 interferon signature in 5 patients with Data2. And actually, the signature did decrease after the starting of TNF inhibition therapy. So in that paper, we hypothesized that interferon signature might be a biomarker of disease activity, severity, and response to treatment in patients with Data2. So as I told you, this is an update. So in the previous paper was 5 patients. Now we reached our cohort of patients. So we have 9 Data2 patients now. And so this is the clinical manifestation. As you can see here, all of our patients carry 2 Data2 mutations, so in homozygous or compound heterozygous state. And all the variants except 2 that you can see down, these 2 were already published and described as pathogenic. And what about the clinical manifestation? 8 out of 9 patients had inflammatory vasculitic phenotypes, and only the last patient, patient number 9, had hematological phenotype with a severe transfusion dependence anemia. So regarding the clinical feature, recurrent fever was, together with the livedo racemosa, were the main and most frequent clinical manifestation present in 6 out of 9 patients. But not all of the patients actually had the classical, the typical livedo racemosa that was described at when the disease was described. Other patients have musculoskeletal symptoms and gastrointestinal symptoms like arthralgia and arthritis, and abdominal pain with diarrhea. Likely only 1 patient had an ischemic stroke that brought some seizures and had a neurological involvement with neurosensorial hearing loss. Regarding the immunological phenotype, 1 patient had hypogammaglobulinemia, and another one had this generalized enlargement lymph nodes and splenomegaly. Not surprisingly, all of the patients had increased acute phase reactant with increased CRP and ESR, except of 3. 1 was the patient with the hematological manifestation, while the other 2, as you can see, that are the patient number 2 and patient number 5, actually has a very mild phenotype with normal CRP and ESR. But when we went to check the serum amyloid A, anyway, they had an increased serum amyloid A ranging from 20 to 60 that maybe could underline a slightly chronic inflammation even in these patients. So all of our patients are in TNF inhibition, and they respond to treatment very well. They actually in clinical remission. And what about the patient number 9 with the hematological manifestation? It's hard to say, but it seems anyway that starting the TNF inhibitor, she's waiting for the bone marrow transplantation. But anyway, the TNF inhibition therapy seems to have prolonged a bit the necessary for transfusion in these patients. So these are the genotype. As I told you, most of them were already published and considered as associated with the disease. What about type 1 interferon signature? As we showed in 2018 papers, the type 1 interferon signature result increase in all of our patients. As you can see in the graph on the right, the type 1 interferon signature was somehow in the middle between healthy control and typical type 1 interferonopathies like systemic lupus erythematosus and Aicardi-Goutieres syndrome. So it's increased, but not that much maybe. What happened with the therapy? Despite there was a global reduction of type 1 interferon, the new patients actually didn't behave like in a linear way, because in one patient, the type 1 interferon signature remained stable, almost stable, and in two patients actually increased after the starting of the therapy. So it was a bit of a surprise. So type 1 interferon is increased in the disease, but I'm not sure it might be used as a biomarker of disease for judging the response to treatment and the clinical remission, because despite the increase of the type 1 interferon, the patients were absolutely in clinical remission. And when I went to check if it could have been, these are median value, so mean values before and after treatment. I went to check if in the date in which the samples were collected, the patient might have had any infection or other symptoms, and it was not, because the ESR, CRP, white blood cell count, the serum amyloid A were all normal. And so apparently, and they didn't display any symptoms, so apparently there was no reason for the interferon signal to be increased. We even checked the CXCL9, CXCL10 levels in these patients, and again, they were increased respect to control, but they didn't decrease in a statistically significant way after the treatment. So what we can see is, what is sure is that the treatment does work. These patients, all of them are in clinical remission, and all of them display a complete normalization of the acute phase reactant parameters, the ESR, CRP, and serum amyloid A. So the treatment does work, the patients are fine, but the type 1 interferon signature is not behaving like a marker. So our patient do confirm the phenotypic variability of TATA2 patient, even among patients in the same family. I haven't told you that two of the patients in the table were siblings, actually, with the same homozygous mutation, and one had a very severe phenotype, while the other has just livedo and recurrent fever. So there is this phenotypic variability, even among patients of the same family carrying the same mutation. All TATA2 patients have a higher interferon score compared to healthy control that didn't decrease in a statistically significant way after treatment. Although in 6 of 9, it did decrease. TNF inhibition is confirmed to be effective in controlling clinical manifestation and in normalizing the inflammatory parameters in this patient. And CXCL9 and CXCL10 were significantly increased, but again, compared to control, but again, didn't change significantly after the treatment. And that's it.